This is Nursing It. Welcome back to part 2 of gynecological emergencies. In this section, we're going to be talking about specific causes of abdominal pain and vaginal bleeding, as well as care of the patient who has trauma to the female reproductive organs and victims of sexual assault. As I mentioned before, the primary causes of people during the reproductive years who have female reproductive organs are abdominal pain and vaginal bleeding. So we're going to go through some of these and just talk about what they are and how they might present and what our priorities of care will be. And you will notice that I'm trying So let's begin by talking about pelvic inflammatory disease, or PID. This is an infection of the female reproductive tract, which is caused by an invasion or infection of bacterium, virus, or fungus. And the organs most commonly involved are the uterus, the fallopian tubes, and the ovaries. PID is the most common cause of abdominal pain in patients of childbearing years. And the cause of PID is usually related to an infection like gonorrhea, which is Neisseria gonorrhea, or chlamydia, which is Chlamydia trachomatis. Because there are no obvious signs and symptoms of infection early on, gonorrhea and chlamydia can both progress undetected in the uterus, fallopian tubes, and ovaries until frank PID develops. Predisposing factors for the development of PID are having multiple sexual partners, a prior history of PID, a recent gynecologic procedure, or the placement of an intrauterine device, or an IUD. PID can be either acute or chronic, and post-infection damage to the fallopian tubes is one of the most common causes of infertility. It causes adhesions, and that can also cause chronic pelvic pain and increased frequency of ectopic pregnancies. One of the things that we notice in patients who have PID is that they have a significant rebound tenderness. So they tend to walk with this shuffling gait, which you may hear people refer to actually as the PID shuffle, where they don't want any bouncing, they don't want pressure to land on their heels, because then that's referred up to the pelvic organs, which kind of then bounce in the pelvic cavity, causing severe pain. So walking intensifies pain. Riding in the car and bumps intensifies pain, and therefore during transport in the ambulance, as you're bumping up and down, the pain may intensify. That might be a nice time to have a conversation with your partner who's driving to ask them to take it easy. Signs and symptoms of pelvic inflammatory disease include foul-smelling vaginal discharge, which is often a yellow discoloration. Irregular menses also are common. The patient may appear acutely ill or toxic when pelvic inflammatory disease is severe. The treatment includes IV antibiotics, sometimes over an extended period of time, or sometimes IM injections and PO antibiotics, depending on the cause of the infection. Our goal is to make the patient comfortable. Obviously, we're not going to perform a vaginal examination. That's not within our scope of practice in the pre-hospital setting. So think about, again, respectfulness, professionalism, position of comfort, Knees drawn up a lot of times will help decrease some of that rebound tenderness. Putting them on their side may help as well. And, asking your partner to drive gently. Ovarian cysts are another cause of abdominal pain, and at times can even have a little bit of vaginal bleeding. So ovarian cysts themselves are small fluid-filled sacs that develop on the outer surface of the ovary, and they can rupture, oftentimes with activity or intercourse, and that causes leaking fluid and blood into the pelvic cavity. Now we know that when organs are damaged or ruptured and blood is in the abdominal cavity, it irritates the peritoneum and can cause peritonitis. Well, the same thing is true usually on a much smaller scale with ovarian cysts, but blood irritates the peritoneum and causes significant pain, which is usually unilateral and can radiate through to the back, and then rebound tenderness as well. Typically the pain is so sudden, sharp, and severe that it causes them to stop whatever they were doing. And if this is the first time that's happened to somebody and it happened during intercourse, oftentimes there's a lot of fear that they injured something. Oftentimes the person has a history of dyspareunia, so they have a history of painful intercourse, as well as potentially spotting in between menstrual cycles, or irregular menses, or even delayed menses, so their menstrual cycle may have been late. Comfort care, reassurance, careful assessment of vital signs to make sure that you're not, missing out on something that looks more ominous, such as an ectopic pregnancy would be important, since this usually is unilateral pain. Cystitis is a urinary tract infection, so it's inflammation of the urinary bladder, and it's a primary cause of abdominal pain, especially in sexually active women. The bacteria can enter the urinary tract through the urethra, which is very short, and then ascend into the bladder, the ureters, and even up into the kidneys. So we're looking for pelvic pain, flank pain, and even kind of mid-back pain, as well as fever or chills, and then any urinary signs or symptoms: urgency, hesitancy, dysuria, which is burning on urination, dribbling or small voids, unable to empty their bladder completely, and even hematuria, which would be blood in the urine if the lining of the bladder is very irritated. Low-grade fevers are not uncommon with a uncomplicated urinary tract infection. When you start to see tachycardia, hypotension, tachypnea, and higher fevers, we start to think of sepsis related to a urinary tract infection, and that obviously would be a much more complicated and sick patient. Ovulation itself can cause pain. This is referred to as Mittelschmerz, or pain in the middle of the cycle. Schmerz being pain, middle meaning middle. So this is mid-cycle abdominal pain. The pain is related to peritoneal irritation due to follicle rupture or bleeding at the time of ovulation. So 14 days prior to the onset of bleeding, the egg is released from the ovary, and that there's a little bit of blood that is released at the same time, and then that cyst kind of heals over. The treatment is just symptomatic. Typically, hot packs or NSAIDs can help, and a lot of women find comfort flat on their back with their knees or legs elevated with warm packs to their lower back, as well as non-steroidal anti-inflammatories like ibuprofen. Endometritis and endometriosis we're going to talk about. The difference really is in the suffix of the word, right? So endometritis, itis meaning inflammation of endometritis, can be life-threatening. So this is an infection of the uterine lining. And we see this typically after instrumentation or disruption of the endometrial lining. And so this could be after miscarriage, childbirth, or gynecologic procedures such as D&C or, like a surgical termination, or some sort of surgery to remove whatever, if somebody had a tumor or a fibroid. So typically what happens is 48 to 72 hours after the surgery, the infection begins, and the person will have mild to severe lower abdominal pain, bloody, foul-smelling discharge, and a fever. Because these people oftentimes are still having bleeding from the procedure that they had, whether it was a delivery or some sort of gynecological, instrumentation, oftentimes the fact that they're having bloody discharge is not a surprise to them. What's different is that it tends to now increase. So typically, after delivery or after procedure, you have the heaviest flow in that first 24 hours or so, and then it should taper off and it should become, a darker brown and then just a lighter yellow, and then it should go back to white. And if it remains bloody or increases in flow, when you're 4 days, 5 days out, then that's a concern. And if it starts to become, green or foul smelling, that's certainly a concern. The fever, however, is obviously the big giveaway that there is an infection. This can cause sterility. It can lead to sepsis. In the postpartum patient, it can lead to hemorrhage, life-threatening hemorrhage, and death. So endometritis is nothing to ignore if you have a patient who presents with vaginal bleeding after some sort of gynecological procedure and they have a fever. You want to treat them as if this is potentially life-threatening. So this patient should definitely be on all of the monitors, oxygen if they're tachycardic or tachypnic, end tidal CO2 if you're worried about blood pressure and hypoperfusion and you want to keep an eye on their CO2 levels, and then IV access, at least 1, maybe 2 if they appear unstable to you at all, if you're thinking that they might be septic, and then, get your fluids started. And, if this person looks acutely ill to you, then you may even want to call a sepsis alert on this patient because, these are people who can go downhill pretty quickly. Endometriosis, on the other hand, osis being the morbid condition of endometriosis, is just having endometrial tissue in places that it does not belong. So while this causes pain and can cause, bleeding and discomfort, it is not life-threatening, not typically something that is treatable or needs acute intervention in the field. So the endometrial tissue itself can be found outside of the uterus, most often in the abdomen and the pelvis, but also in the GI tract, so like in the rectum, in the nervous system, even the central nervous system, and in the respiratory tract. It goes through this same cycle of engorgement and then sloughing and bleeding as the regularly located endometrial lining does. And so, people may have severe, abdominal pain from bleeding in the GI tract or from bleeding into the peritoneum and causing some, mild irritation and peritonitis. If it's in the respiratory tract, it can cause, respiratory inflammation. And obviously, if it's in the nervous system, that can cause some nervous system issues as well. So the inflammation from the bleeding causes pain, especially in the abdomen. The inflammation of the peritoneum can cause scarring and adhesions between structures within the abdominal cavity. So we can start to get adhesions and then even, leading to fistulas between the bladder or the uterus and the vagina and the rectum and, other parts of the colon. So that can become a concern for us as well. We see this most often in women between the ages of 30 and 40. They don't really understand the cause, but the diagnosis requires like surgery and kind of studying the tissue. The patient presents with a dull, cramping pelvic pain, usually related to menstruation, painful intercourse, and abnormal uterine bleeding. Oftentimes, this is diagnosed as they're being evaluated concurrently for fertility problems. The treatment is hormones, analgesia, usually NSAIDs, and surgery. Ectopic pregnancies are a life-threatening condition, potentially, so we should treat all of them as kind of the worst-case scenario until we have proven otherwise. And this happens when there's implantation of the fetus outside of the uterus. The most common site is within the fallopian tubes, and we kind of talked about like a history of pelvic inflammatory disease or endometriosis. Things like that can really increase the risk of an ectopic pregnancy, and prior history of ectopic pregnancies also really increases the risk of a subsequent ectopic pregnancy. These are considered a surgical emergency because the tube can rupture, which can trigger a massive hemorrhage. There's blood vessels all around those tubes. So the signs and symptoms are severe unilateral abdominal pain, which could radiate to the shoulder on the affected side, and late or missed menstrual periods and vaginal bleeding. So whereas with the cysts, those tend to radiate more towards the back, the ruptured ectopic pregnancies tend to radiate more towards the shoulder. And by the time you have bleeding, that means that rupture has occurred. So if you have pain with no bleeding, that's a really good sign, and that's reassuring because we don't want bleeding. And once you have the bleeding, that's a really bad sign, and that means that you should have 2 large bore IVs and you should have fluids at the ready, and you should be driving quickly to the hospital. So how do we manage GYN-related abdominal pain? Treat them as we would every patient, transport to the hospital in the position of comfort, administer oxygen to maintain a SAT of 94 to 99%. Vital signs should be as appropriate for the patient. So if they're stable every 15 minutes, if they're unstable every 5 minutes, monitor them as you would any other patient based on your gut instinct, right? So, if you feel like they need to be on the cardiac monitor so you can really watch their heart rate, or end-tidal CO2 because you're worried about end organ perfusion. And let's just say that, remember that mental status is the primary sign of adequate end organ perfusion. So if you have a patient who's anxious or restless, that in and of itself is a good indication to put the patient on end-tidal CO2 so you can watch to see if you're having perfusion problems, right? Get a glucose if you have altered mental status or history of diabetes. And then IV access and fluids is indicated to maintain a MAP of 65 and help maintain that normal mental status. Make the patient as comfortable as possible, be respectful, and reassuring. Always calculate a GCS so that you can tell whether or not it's changing, especially in patients that aren't quite a 15. Non-traumatic vaginal bleeding itself is also, so we had the abdominal pain, so non-traumatic vaginal bleeding is one of the other major causes for calls. The most common cause is the loss of a pregnancy, which is referred to as a spontaneous abortion or a miscarriage. And the person will experience cramping abdominal pain, passage of clots and tissue, and this can be a very significant emotional event for the patient. So it's really important that you're kind and considerate and allow them to grieve. And probably one of the most important things that we can say to people is like, it is okay for you to feel that this is a loss. Like, it's okay for you to have really been excited about this, even though like you had never met this baby, and you may feel really sad about this now or even later on. And if you're feeling, really sad and you're struggling, then you need to find somebody to talk to and really give people permission to feel that loss and to grieve, because even though it's not like an actual physical being that they've held in their hands, it's a physical being that they have experienced in their mind and in their heart. Uterine fibroids, which are also referred to as leiomyomas, are non-cancerous tumors that develop in the uterus, and those are another common cause of vaginal bleeding. Typically see this in women in their 30s, and they tend to be more common in our Black population. The signs and symptoms are vaginal bleeding, heavy periods, abdominal fullness or swelling, and again, pain during intercourse. Sometimes the bleeding associated with fibroids can be controlled with hormones, but the actual cure for those, aside from, they tend to decrease during pregnancy, is a hysterectomy. Dysfunctional uterine bleeding, or DUB, is rarely seen in the field unless it's severe. And this is bleeding when you don't expect someone to have a period. And we talk about DUB in our postmenopausal patients. So this is something that you might get called for a patient who is over the age of 55-ish, who has had a cessation of menses and who starts to have some bleeding or spotting again. And this is not a normal period. It's not like every 28 days they get a period. It's that they are experiencing bleeding when they wipe or blood on their underwear, and that's not expected or normal for them. So that oftentimes is associated with uterine cancer. And it is important that they get seen, but typically it's not an emergency that we get called for unless they're hemorrhaging. Menorrhagia is the term for excessive menstrual flow. Again, not something that we commonly get called for unless the person was having like syncopal episodes or had some sort of bleeding disorder. And it's important to remember that hemorrhage, regardless of the cause, always has the potential to become life-threatening. So monitoring carefully for signs and symptoms of shock really is important, and then treating appropriately as well. So it's important that we absorb the blood flow, but we don't pack the vagina. So nothing goes into the vagina. And this is important in the field, right? So we don't put our hands in there, we don't put tools in there, and we don't put gauze in there. The only exception to that is during a delivery, if there is a prolapsed cord or a breech part, we would use a sterile gloved hand to relieve pressure on the cord or the part. Other than that, we don't do any vaginal anything in the field. Everything is just external examination only, and that includes padding. If the patient's passing clots or tissue, you want to save those to be evaluated by the physician. Again, if it is a fetal demise and it's a loss of a pregnancy, they may send the tissue for evaluation if there's some concern that there was like an abnormal development, especially if it's a recurring issue the patient is having. Transport the patient in the position of comfort, and they will let you know what that is. They may want to be on their side or knees drawn up, or they may want to sit. Oxygen therapy to maintain a sat of 94 to 99%, IV access if indicated, and again, fluids to maintain a MAP of 65 and a normal mental status. And then the rest of your monitors and checking glucose for a history of diabetes or altered mental status, things that just make sense. And don't get distracted by the fact that this is a GYN patient, because it is still a patient. We can have trauma related to the external and internal female reproductive organs, and this could be related to foreign bodies, sports, physical and sexual assault, childbirth, so like a field delivery, and seatbelt and other blunt force injuries that occur in the low abdomen and the pelvis. So traumatic gynecologic emergencies are things like blunt force trauma to the lower abdomen area due to assault or seatbelt injuries, and the blunt trauma occurs more frequently than penetrating trauma. Straddle injuries are a common form of blunt trauma, and I mentioned that in the last video, but like when you are on a bicycle that has a high bar on it and you slip forward off of the seat and land on the bar, or a gymnast that lands straddle on the beam. So things like that, like any sort of straddle injury can cause especially external trauma. Vaginal injuries most oftenly have lacerations due to sexual assault, but the vaginal tissue itself actually heals very quickly, and so oftentimes those are kind of limited and self-repairing. Foreign bodies inserted into the vagina, self-attempts at abortion, and lacerations following childbirth are all ways that the reproductive tract can suffer trauma. Again, nothing in the vagina, direct pressure over the lacerations if you can see them externally. If there are any hematomas, you can take a chemical cold pack, wrap it in a towel or a washcloth, and place it over the hematoma. Please don't ever put anything ice or cold directly on the skin. If there are signs and symptoms of shock, establish an IV, monitor those vital signs really closely, and never pack the vagina with any material or dressing, regardless of the severity of bleeding. So let's talk about sexual assault for a few minutes. There are more than, or almost just shy of 1 million women who are sexually assaulted annually that report it. So it's probably a much larger number. Most victims know their assailants, and the acquaintance rape is common among adolescent victims. Sexual assault is motivated by aggression and the need to control, humiliate, or inflict pain. It is a crime of violence, not a crime of passion. The perpetrator usually has poor impulse control, immaturity, and a need to achieve sexual satisfaction within the context of violence. So the definition of sexual assault is any sexual contact without consent. The definition of rape is penetration of the vagina or rectum of an unwilling person. And so that could be, male, female, or other. Sexual assault includes oral genital sex. It's important to remember that the patient needs both emergency medical treatment and psychological support. We need to be careful because this is a crime scene, so legal evidence has to be gathered, and you need to be very careful in both what you say and how you act and how you document, and be objective. Do not ask questions about specific details of the assault. And that's true even in the ER. If I'm triaging somebody who has had an alleged sexual assault, I don't ask any questions. I ask, are you bleeding? Are you hurt anywhere? And are you in pain? Right? And then, other than that, the sexual assault nurse examiner and the physician will ask the rest of the questions that they need to ask. But I don't want to make this patient relive this experience over and over again, knowing that other people are going to have to ask those questions. So confine your questions to physical injuries that the patient has received, and approach the patient calmly and professionally to help allay their fear and anxiety. If they are incompletely dressed, cover them up with a sheet, and respect their modesty as much as you can. Explain all your procedures to them to help kind of alleviate those fears, and obtain permission before beginning them. And you may feel like it's your first day on the job, like, I'd like to take your blood pressure. May I put the blood pressure cuff on your left arm? It's important that you have consent, because this person just experienced something where somebody took away their right to choose. Avoid touching the patient other than take vital signs or examine any stated physical injuries. Do not examine the genitalia unless there's life-threatening hemorrhage. Keep in mind that the patient may have been drugged, and so there might be some altered mental status. And then maintain a non-judgmental attitude and assure confidentiality. Let the patient choose who they want to ride in the back with them if that's appropriate. So sometimes the patient will prefer to have a male or female partner, or sometimes our provider, and sometimes they may just kind of feel more comfortable with one person over the other. Don't read into it, and don't feel offended if they don't choose you. There might just be something about the fact, you know, like your partner may have blonde hair and their mother may have blonde hair, whatever. It doesn't, don't read into it, because it's likely not personal at all. It's nothing that you did. Preservation of physical evidence is really important. And as I mentioned, this is a crime scene, so you have to protect that scene. Handle the clothing as little as possible, if at all. If you have to remove the clothing, bag each item separately into a dry, clean paper bag and label them. Don't cut through any tears or holes in the clothing, because those could be swabbed for evidence or used to reconstruct what happened. Place bloody articles in brown paper bags. We never want to put anything wet or bloody in plastic. And again, don't examine the perineal area. If the assault took place within an hour or the patient is bleeding, you could put an absorbent underpad under the patient's hips to collect that evidence. So like a gauze or an ABD pad or something like that. I can tell you that you know, talking to the sexual assault nurses, they have said that sometimes, like when the patient urinates, they save the toilet paper, so they have the patient like blot themselves with the toilet paper, and then they actually save that toilet paper, and there has been semen on the toilet paper that they have been able to use to convict an assailant. So it's really important that we like keep that, all the evidence possible. If you do cover the patient with a sheet or a blanket, it is evidence, so make sure that you turn it over. Do not allow the patient to change clothes, bathe, or douche before medical examination. If the patient insists on changing, you know, hopefully the police are there, but if not, ask them if you can collect the clothing to take with you, and again, place it in paper bags. Do not allow the patient to comb their hair, brush their teeth, or clean their fingernails. And again, when we say do not allow, I mean ideally, right? But this is to preserve evidence. And sometimes people will shower, bathe, burn their clothes, whatever, before they call. We don't have any control over that. But whatever you can do to preserve that evidence would be great. Document any evidence turned over to the hospital staff and the name of the individual that you gave it to. And that's really important for chain of evidence, because if this does go to court and, you know, they say, you know, Nurse X, how did you get that clothing in that bag? And, you know, they're trying to pretend like, you know, a family member created it or something, you'll have a record that you bagged it on the scene and that you gave it to the patient. Do not include your opinions as to whether the rape occurred or not, or the sexual assault occurred or not. And don't clean the wounds if at all possible, just cover them. So to summarize, there's usually very few interventions that we actually can do for gynecologic emergencies, but you can do a great deal for patients' emotional needs. So make sure that while you're staying very alert and attuned to the fact that there are certain conditions that could cause life-threatening emergencies, the majority will not. General supportive care, basic IV therapy are the primary measures that paramedics will use for these types of emergencies. And then trust your instincts. And if your instincts tell you that that person is sick, then, you know, ramp it up. Put the patient on all the monitors, use your end-tidal CO2, you know, start those fluids, make sure that you're treating appropriately for the condition of the patient, but always remain calm and in control, at least on the outside, and reassuring for the patient. Place the patient in the position of comfort. Again, a lot of times drawing the knees up is going to help a lot. And it's more important that the patient be treated symptomatically with dignity and respect than to have a definitive field diagnosis. So don't feel defeated if you don't know what's wrong with the patient, because it's going to take labs and imaging to figure this one out. It's okay. Just be nice. The patient care is definitely your top priority. beyond your own self-safety.